It works? Okay. I'll stop presenting here on my screen. We'll see. Does that work? Okay. That's weird. Okay. Well, I'm Ben. For those who don't know, I'm Ben, one of the PGY2s here. Going to discuss the new limits of outpatient fracture management. Disclosures, I have none, although I am for hire. Brief outline here of what we're planning on doing today and covering. Not advancing. I'm not able to get to that screen at all.
I want to stop sharing and share again.
I'm not seeing it. I don't know if you want to come up here, Susan. This is all I don't think I can get. Oh, there we go. We'll see. Looking funky on my end again. Okay, well, let's go with that. All right, I'll start with case one here. This is a 31-year-old male, fell backwards off a ladder, had obvious ankle pain, was found to have on imaging disclosed pilon fracture, was neurovascularly intact, placed into a short leg splint, ultimately underwent ORF of this right ankle. Case number two, KS. This is a 22-year-old male who sustained bilateral GSW wounds. After being pistol whipped, he was found to have bilateral intra-articular distal femur fractures. He was neurovascularly intact. Each wound was washed, closed in the ED, placed in knee immobilizers, and ultimately underwent bilateral ORF of the intra-articular distal femur fractures within the same surgery. Case three, BF. This was a 26-year-old male who was unrestrained in MDC, suffered a significant non-orthopedic injury burden, including pneumothorax, pulmonary contusions, sternal fractures, rib fractures, liver lacerations, but also had this, from an orthopedic perspective, this intra-articular calcaneus fracture. He was found to be neurovascularly intact, placed into a short leg splint. Ultimately underwent ORF of the calc with a subtalar fusion. And finally, case four, this is a 44-year-old female who tripped over a pallet, had a closed left intra-articular distal humerus fracture, was placed into a sling, and ultimately underwent ORF of the left distal humerus fracture. So what did all four of these cases have in common? The night before and the night after surgery, the patient spent in their bed on the left, not the bed on the right. All of us in orthopedics are very aware of some of the headlines that are out there. First outpatient procedure performed, orthopedics, what are trends? Things are moving outpatient. And the reality is, due to COVID, we've seen an acceleration of this. There are diversions at hospitals, or that patients are waiting hours in the emergency department. They're boarding patients in the emergency department. They're not getting rooms. Cases are getting canceled from an inpatient perspective due to staffing issues. And we're seeing reports like this. This woman was out of northeastern Charlotte. You're seeing elective surgeries that are obviously being postponed because there's not inpatient bed availability. While COVID is temporary, or hopefully somewhat temporary, although at this rate, who knows, it's helping accelerate the natural transition that's occurring within orthopedics. The old approach, patients would present to the ED around 4 p.m., knee pain, imaging obtained, orthos consulted, make the diagnosis, possibly a plateau fracture from a low energy mechanism. Patient, ortho sees the patient, consents the patient, makes some NPO, take care of any splinting that needs to occur in the emergency department, and then tentatively book them for first case. Well, one delay leads to another. Next thing you know, patient gets up to the floor, it's after midnight, they want some food, they're hungry, they're NPO, patient can't fall asleep, is nervous for surgery, 3 a.m. rolls around, this comes in. Now this patient's no longer first case in the morning. This happens again, and next thing you know, this patient is bumped to the next day. So you have to ask yourself, well, could this patient have gone home? You ask, well, has this ever been done before? A JBJS article from last year analyzed looking at patients from managed inpatient, could they be transitioned to outpatient? And they set a goal to implement 80% of procedures to be done as an outpatient. It was initially established as a QI project. They found that the inclusion criteria or exclusion criteria was patients who were poorly controlled, medical comorbidities. They were unable to mobilize safety. They lacked social support and had open fractures. They were kept in-house, but the rest of the patients, they attempted to try to move them outpatient setting. And ultimately, it was a policy change that allowed for the booking of outpatient urgent room cases, education for patient and nurses, and development of a standardized outpatient pathway. And the results were pretty astounding. Within the first 4 years of this study, but really within a year is looking at this data, they increased their outpatient fracture management from 1.6% to 89%, and they decreased their average length of stay from 2.8 days to 0.2 days. Patient satisfaction remained high, and there were no safety concerns. Looking at the chart on the left and breaking it down a little bit for you, you can kind of see a stepwise increase in the percent of patients who were managed in an outpatient setting with each change. One, when they allowed booking of outpatient cases. The second was when they increased PACU and ED mobility training. And the third was the implementation of a standardized pathway. And that got us from 2% to 89% managed outpatient. And then you look at length of stay, and concurrently in a stepwise fashion decreasing. You saw the data change as well to where patients were having their average length of stay being 0.2 days at the end of their study. We always have to ask ourselves, well, okay, great, we're moving them outpatient, but is it actually safe for the patient? Our arthroplasty patients have begun to look at this, and Dr. Springer and Dr. Beaver did a retrospective study a few years ago that looked at 243 patients, 137 were managed in an outpatient setting, and they compared 30-day readmission rates between patients undergoing inpatient versus outpatient total joints. And they found there were no statistical differences in 30-day readmission or unplanned care episodes between the two groups. Interesting to note, they actually found the total knees had more readmissions than total hips in general, but they were non-different for the inpatient versus outpatient groups. Looking at our spine colleagues in CNSA, Dr. McGriff and Dr. Adamson, they have a long case series going of over 2,000 ACDFs 1 to 3 levels that were performed at ambulatory surgery centers between 2006 and 2018. And what they found was their all-cause 30-day readmission rate was 1.9%. And they recommend ambulatory surgery centers when utilizing proper patient selection and 4-hour PACU stay. I found the 4-hour PACU stay to be very interesting because that's what some poor literature, but they cited that most neck hematomas and serious medical complications would present within 4 hours. And they felt that that was an appropriate timeline to monitor patients and be able to send them home after the surgery. Looking at this study out of the University of Iowa, this was a retrospective study that looked at lumbar discectomy, single levels. They tried to compare inpatient versus outpatient patients and looked at over 4,300. And after propensity score matching, trying to eliminate for selection bias, they found that the overall complication rate was significantly less for patients managed outpatient as opposed to inpatient. Now, discussing our trauma folks and circling back to more fracture management, this study out of the University of Chicago published in JBJS a few years ago looked at an 8-year retrospective analysis comparing 1,800 inpatient versus outpatient closed ankle fractures. And they found that outpatient closed ankle fractures were associated with significantly fewer complications such as UTIs, pneumonias, VTEs, blood transfusions, and reduced 30-day medical morbidity. And probably equally important, they found no increased rate of surgical morbidity, reoperations, or readmissions. But how do the patients feel? Well, this was back from the first JBJS article where they implemented the pathway. And patients were asked 3 questions. They were asked if they felt like their healthcare needs would be taken care of when they left the hospital, if they had a good understanding that they were responsible for their own health, and if they felt like they understood the purpose for taking each medications. And while this questionnaire has its own limitations because there's no baseline, it's not a randomized control trial, obviously patients felt like they were taken care of. They either agreed or strongly agreed with each of these 3 statements. Are there ulterior motives for us? Well, obviously, it's no secret that we spend a lot of money in orthopedics in regards to healthcare. And in orthopedics, we're often tasked with measuring value. And this JBJS article referred to value as health outcomes per dollar spent. There's ways we can try to calculate this cost, and there's standard different accounting mechanisms such as cost accounting, job order cost accounting, and time-driven activity-based costing. And by moving things to the outpatient world, we can affect some of these areas, such as overhead, facility depreciation, or if you're looking at time-driven activity-based costing, inpatient hospital stay, and pre and post-op eval times. And why is this important? It's because our patients are bearing more of the cost. Between 2009 and 2019, insurance deductibles rose by 162%. More Americans are paying out of pocket than ever due to increasing frequency of cost containment and catastrophic-only policies. Anecdotally, my own out-of-pocket maximum has tripled in the past 5 years. So comparing these ankle fractures managed between inpatient and outpatient, the study was published in the Journal of Foot and Ankle Surgery from Ohio State University, looked at over 11,000 inpatient and outpatient managed ankle fractures. And importantly, that they found that there were no increased rate of complications, they had lower rates of pneumonia, MI, AKI, UTI, and pressure ulcers. And they found that they actually saved on average $9,000 between patients that were managed on the outpatient as opposed to the inpatient setting. One question always that comes up is, what about pain control? You're sending these patients out with acute fractures. How are they going to be able to manage their pain? Well, Dr. Shu obviously has done a lot of work with this in the 2019 JOT article that looked at establishing clinical practice guidelines for managing pain management and acute musculoskeletal injury really focuses on a multifaceted or multidimensional approach between expectations, medications, injections. And expectations may be the most important. You got to establish these from the beginning, understand that patients have major musculoskeletal injury, that their injuries are going to hurt, and that we're going to do what we can to try to assist them with their pain, but it's not only just going to be flooding them with opioids. And also having patients understand that we are hamstrung in many ways, a good way, by the government in regards to pain medicine. Again, furthering kind of the medication talk, oftentimes there was not really a guideline. What do we do for acute, major or minor musculoskeletal pain management? Again, within this paper, they demonstrated the major and minor criteria and helped prescribing guidelines for surgeons as they're trying to manage these injuries. But what about injections? Hip fractures actually have some of the strongest literature, and that revolves around the fascia iliaca block. They found that these blocks can decrease VAS scores, reduce narcotic consumption, decrease delirium in at-risk patients, and actually received a strong recommendation from the Academy in their clinical practice guidelines. Looking at for our upper extremity folks, this was a randomized control trial done at the University of Penn back a few years that looked at 36 patients who had distal intra-articular distal radius fractures, and they found that patients actually had early better pain control within the 2-hour window. They did have some rebound pain between 12 and 24 hours that was equal with the non-block group, but they found these patients had decreased recovery room time and a significant decrease in opioid consumption in the block group with equivalent functional outcomes at 6 and 12 weeks. Looking more at acute fractures of lower extremity injuries, this study back from 2018 looked at tibia and ankle fractures, general anesthesia versus regional block. Interesting to note, this study did not specify what was, they excluded compartment syndrome, and they purposely didn't specify very well what was the considered high risk other than it was attending discretion for compartment syndrome. But what they found was the patients had similar pain scores and they had less time in severe pain, and patients had overall much higher satisfaction with their pain control in the block groups. But another weakness of the study is it didn't evaluate the amount of pain medication received. So we say to ourselves, well, what about compartment syndrome? Obviously, especially with tibia fractures, that's a concern. Dr. Rice looked at 191 tibia fractures. It was a retrospective study done here. 51 patients received regional anesthesia, 140 didn't. 0 patients developed acute compartment syndrome in the block group. Of note, we looked at just possible sequelae of missed compartment syndrome, which included intraop myonecrosis, foot drop, sensory disturbances, AKI, among others, and they found that the potential signs of missed compartment syndrome was less in the group that received regional anesthesia, or was similar, I should say, between the group that received regional anesthesia and the group that did not. Ultimately, patients also had similar 24 and 48-hour pain scores, which were reported. The problem with compartment syndrome and regional anesthesia is that no one's willing to do a randomized controlled trial. Obviously, the long-term sequelae of this injury is devastating for these patients, and so it's very difficult to establish an appropriate trial. But this meta-analysis looked at over 20 low-quality articles and broke them up by each anesthesia type between regional, spinal, and IV. And what they found was in these case reports, there was no delay in acute compartment syndrome in the regional groups, but there was a delay in acute compartment syndrome diagnosis in spinal and epidural. And the conclusion from that was that no data that regional anesthesia actually masks the sign of acute compartment syndrome. What have we learned ourselves? Well, we've started transitioning more and more patients to the outpatient world and tried to implement our clinical practice guidelines and how we were going to manage their pain control. And in doing this, we were able to look at what procedures we did at one-day surgery. And we looked at acute fractures, subacute, non-unions, and deformities, and ultimately pain control for our patients. And we found was out of these 151 patients, only 1 patient ended up having to be admitted due to poor pain control postoperatively. We also looked and said, well, what patients went home and came back to the ED? And we found that we had 2 patients who came back to the ED within 1 week due to pain control, and another 2 that presented within the first month. So still relatively low. We're talking about 1% of the patients who ultimately bounced back due to severe enough pain issues where they felt like they couldn't be managed at home. But ultimately, none of these patients were admitted from the emergency department. So circling back, each of these patients shown initially, the 4 patients that I saw, they didn't bounce back to the ED. 1 patient did call the next day, said he was having significant pain, but then said that he didn't pick up any of his pain medicine and re-prescribed him and did not call back, had no other issues there at his first post-op visit. There were no documented complications, and you can see that obviously we're fixing, pretty bad injuries for these patients, intra-articular calcaneus fractures, pilons, and these patients are doing well and going home. But change is oftentimes difficult. There's a lot of A lot of things that have to happen, equipment, process, procedures, people, environment, that all need to be on board for successful implementation of outpatient fracture management. And focusing on the 4 areas, you can start with equipment. Equipment needs to be available. You need to have adequate splinting materials, which for us at Maine is not really a concern here. But crutches, wheelchairs, and also implant availability. If you begin to move these patients into the outpatient world, you're going to need to have, maybe it's a tibial nail, maybe it's the cannulated screws that normally wouldn't be at a surgery center or an outpatient facility be readily available for these cases to then occur. You also need to, change the process, because OR booking, it's very rare now to be able to book directly for cases the next day or 2 days away. As a resident, PACU needs to have significant process improvements, mobilization training, have physical therapy available on call, more medication education, and then ultimately these patients are going to be sending them home, and they need to feel like they have readily available support tools, communication tools, such as My Atrium Health, that they can easily access and respond to providers quickly, and that the providers are actually able to respond. Briefly, just want to show, I'm not sure how many of you have actually looked at what My Atrium Health is and what patients see. But as you log in, you can click on health messages, and right there is where you can communicate with your providers directly. And that would be a way that you could help implement a process for outpatient fracture management. But ultimately requires a cultural shift throughout the healthcare system, and one where you trust the process. Looking at people, it has to be buy-in from everybody. From anesthesia, they might have to be willing to do more regional anesthesia and regional blocks. From the OR nurses, they may be doing different cases. From the staff nurses, they might be reaching out to other patients more frequently as they're reaching out post-op day 1. What about ED nurses? They need to be more adept in managing mobilization and pain control, having case management and physical therapy available, especially for the ED, where they can help with disposition plans for difficult patients. And then us as residents and APPs ultimately being the ones that decide, do you think these patients would be amenable to outpatient surgery? You need attendings to buy in and say, okay, I'm willing to start having these procedures be done in an outpatient setting. And then ultimately administration and having buy-in with certain block time and allowing the process to be put in place that will allow these patients to be managed in an outpatient setting. And then ultimately, I kind of touched on this already, the ERs and the ORs needing to make little adjustments to them to manage these patients more effectively on an outpatient basis. The 5th area that really isn't discussed as much, but it's patient selection. This is what comes down to us as providers, residents, APPs especially. Obviously, anesthesia has their own concerns, and certain facilities, outpatient facilities, have their own guidelines, like ours at 1-day surgery. Some of them are pretty easy, BMI greater than 55, uncontrolled diabetes, us as residents can pick that up, but there's other ones that are a little bit more nebulous, like difficult airway. It's like, okay, well, us as orthopedic residents, are we really the best to decide what is a difficult airway? Maybe or maybe not. And then there's some of this gray area with the patient support system. Do they have a ride? Is someone there willing to assist them with meals? Do they have a working cell phone that they'll actually use and answer? Do they have pain tolerance? Was their buy-in initially in the emergency department? If you can't control their pain at the ED, it's unlikely that it'll work at home. You ask yourself briefly, what does the future look like? Well, AI might be something down the road. The report that AI can help predict clinical outcomes based on data sets, genomic information, medical images, may ultimately help us stratify the right patients for outpatient surgery through machine learning. What about remote patient monitoring? We've already starting to get fairly good at that as a healthcare system because of COVID. We're monitoring these patients at the hospital, at home. We're sending them home with blood pressure and heart rate machines and respiratory rate checks, and we can maybe be able to manage and monitor these patients before there's even issues that patients are aware of at home. So ultimately, what does implementation look like of this? Well, the patient is going to come in, diagnosed with a fracture. You're going to have to say, is this operative or not? Once the decision is made, then it's up to the on-call orthopedics, most likely the residents or the APPs, to say, do we think this patient meets the criteria for ambulatory pathway? Well, then if they do, then you need to work on trying to get them ready, possibly get them booked, have them mobilize, have all the education that they need, and ultimately, get them up to speed and NPO and possibly ready at home so that they can come back the next day or 2 days from now and get the surgery that they need. But obviously, if they don't meet this pathway, then they just come in, they're admitted, and they're kind of our standard way of treating these patients. So ultimately, for successful outpatient fracture management, it comes down to the right patient, the right support system, the right expectations, and ultimately some level of shared decision-making, getting buy-in from the patients that they're invested in their own health and they feel like this is the right thing to do. I thank Dr. Hsu, Dr. Seymour, Dr. McKnight, Dr. Losant.
Ben, that's a very timely talk, but given the sort of the COVID situation, obviously, but I commend you for your recognition of the need for a systems level change. That's really the barrier here, is that we're not set up for this. We're not designed for this. It's not what we think about. But we many of us who were on the Bariatric Leadership Committee call yesterday heard that everybody knows through COVID, we've had this hospital at home, which is for COVID patients. They're actually working, what is it called, surgery at home? Surgery at home. Steve Briggs is one of our urologists, is actually trying to develop a pathway by which we're able to treat more problems and provide patients more support as an outpatient. So outpatient wound therapy, outpatient IV antibiotics, which all fits into the same sort of system that you're looking at. Probably the biggest lesson I think we've learned that you did nicely pointed out about follow-up and access for patients when they go home is the outpatient total joint model, where they've done a really nice job of preventing bounce backs by having calls that call post-op day 0 that night, post-op day 1 the next day. Make sure you do this, timing these outpatient procedures so they happen in the morning and not at 5 o'clock at night. So somebody's going home and having their first problems at midnight when their MyAtrium message is not answered by anyone. So I think that you're spot on with your comment that this needs to be a systems level change. But I think we've all seen, there are tons of negatives of this pandemic for the last, moving on towards 2 years now. But the acceleration to change has been pretty remarkable. So I think this is a great example of something that we probably are heading the right direction for.
Yeah, great talk. One little follow on to Josh's comment is that when we visited New Albany to learn about outpatient total joints, asked them what's the one thing that most reliably and most safely. They said PT. They said you got to have direct integration of your physical therapy group because they were always in the ER calling PT, waiting for them to come. And that was always a rate limiting step. When we think about all the issues that really are the barriers you get now, a lot of it's mobility. So you mentioned the wheelchairs and braces and the crutches and the training and all of that. That's physical therapy. One of the really nice things here that's just happened recently is we've been able to align outpatient physical therapy under the NSKI. So now we'll be working much more closely with them to help make sure that goes through.
Ben, I think that was a good talk. One of the things that I wanted to highlight, I think the biggest thing is the cultural shift that occurred when we started doing this a few years back, because it's a game changer when the APPs and the residents really start to speak in a language around, some of these outpatient fracture management. And, you could have easily showed bicondylar plateaus and femoral non-unions. All this stuff has shifted, at least in my practice, to the outpatient center. And I know that a lot of my colleagues have done the same. And our regional subspecialists have been doing this already for years as well. But it's really it's a cultural shift that starts in the ED, as we've discussed, with the residents and the APPs who initially see the patient. And then in the clinic, down to the people who answer the phones in the clinic, the nursing staff, the MAs. But after a while, there is some tremendous inertia to get going. But then after a while, it just really became the way that we do business to a certain extent. And it's gotten easier and easier and easier over the years.
Thank you, everyone.
Thank you, everybody.
I think we can, numbers wise, we'll be okay.